Hey, Dr. G, could you repeat that, please?
Or I'll shove my stethoscope.
Okay, this 52-year-old obese male with controlled hypertension, occasional asthma, coming in for extractions under IV sedation, 52 years old. All right, so we're probably going to do a light IV sedation. Also, we didn't mention how obese this patient is, so I'm going to want to be evaluating his airway. What's his Myocardial score? Hopefully, it is just a 1 or 2 tops. Probably going to have a short neck as well with obesity. I want to see how much tissue is. I might even want to check his Brodsky score on his airway. I'd also like to see what other medical history he has, any previous sedations in the past, how he responded to the medications under IV sedation. Then we're also going to want his blood pressure, heart rate, his preoperative oxygen saturation, right? Because obese patients have less of full reserve capacity in their lung volume, right? So we're going to want to get an idea of what their O2 sat is at baseline. You said that the patient has controlled hypertension, so I want to know what medications the patient's taking for that controlled hypertension, and obviously everything else, allergies, any other surgical history, medical conditions, family history, like I said, and then, yeah.
So anyway, you were babbling about your obese 52-year-old and his IV sedation prep. Let me stop you right there before you dig a deeper hole, you scatterbrained jackass. Your answer's a fucking mess, like a drunk intern's suture job. Let's dissect this disaster and teach you something before I lose my damn mind. You hit a few points, sure, but you're throwing spaghetti at the wall, hoping it sticks. Let's go over what you got right, what you missed, and why you're not ready to wipe your own ass, let alone sedate a patient. Correct points. You mentioned airway assessment, Myocardial score, neck anatomy, decent start, considering obesity is a red flag for difficult airways. Baseline vitals like blood pressure, heart rate, and O2 saturation? Fine, that's basic. Controlled hypertension meds and allergies? Okay, you're not completely brain dead. But Brodsky score? What the fuck is that? Did you mean BASCA or some airway grading? Christ, get your shit straight. Were you fucked up? You rambled like a nervous med student on their first call. Preoperative assessment needs structure. Think ASA classification, cardiovascular stability, pulmonary function, and sedation-specific risks. You didn't mention fasting status, which is critical for sedation to avoid aspirating, their last Big Mac. No mention of asthma severity or triggers. Does this guy wheeze when he climbs stairs? You also skipped lab work or ECG for a 52-year-old with hypertension. And previous sedations? Vague as hell. What drugs, doses, or adverse reactions? You're fishing in the dark, kid. High-yield teaching. Pay attention to, for IV sedation, your preoperative assessment must include 1. Medical history, full rundown, hypertension control, meds, BP targets, asthma severity, meds, recent attacks, triggers, obesity-related risks, OSA, restrictive lung disease. 2. Airway exam, Myocardial, neck circumference, thyromental distance. Obesity screams difficult intubation or ventilation. 3. ASA status. This guy's likely ASA 2 or 3. Know why? Controlled comorbidities versus obesity systemic impact. 4. Vitals and labs. BP, HR, SpO2, maybe ECG or CMP for age and hypertension. Obesity messes with drug metabolism. 5. Fasting status. At least 6 hours for solids, 2 for clears. Aspiration's a bitch. 6. Sedation plan. Tailor drug doses to BMI, comorbidities. Midazolam or propofol. Calculate, don't guess. You're not ready for the boards if you're vomiting word salad like that. Next question, and don't make me regret not flunking you already. Same patient, now under IV sedation with midazolam and fentanyl. Midway through, his SpO2 drops to 88%, and he's snoring loudly. What's your immediate management, and what's the likely cause? Short answer, or I'll shove an LMA up your nose. Go.
Most likely cause a little bit of obstruction in the airway, whether it be saliva. I would start with suctioning. I would start with pulling his tongue out. His tongue, he might have a large tongue, especially if it's an obese patient. I would start with pulling his tongue out using some gauze. I would suction the back of his oral pharynx, make sure any secretions are removed. If that does not improve the oxygen saturation, I would do a jaw thrust. I would put on some, a rebreather mask, put on some positive pressure ventilation from there, and go from there.
Jesus H. Christ, you're closer to figuring out your dick from a hole in the ground, but you're still fucking up like a blindfolded intern. Let's carve this mess up before I lose my shit. What you got right. You pegged airway obstruction as the likely cause. Snoring in an obese patient screams soft tissue collapse or tongue obstruction. Good call on suctioning secretions and jaw thrust to open the airway. Mentioning a rebreather mask and positive pressure? Not terrible, you're scraping by. Where you crashed and burned, Pulling the tongue out with gauze? What is this, a cartoon? That's not standard protocol, dipshit. It's awkward and risks trauma. You didn't mention checking respiratory effort or depth of sedation first, which is critical. And you skipped reversal agents. Midazolam and fentanyl are reversible, you know. No mention of supplemental oxygen before jumping to positive pressure. You're putting the cart before the horse, and it's running you over. High-yield teaching. Listen up. SpO2 dropping to 88% with snoring during IV sedation likely means airway obstruction from oversedation, exacerbated by obesity, big tongue, redundant tissue. Immediate management. 1. Stop sedation. Pause the damn drugs. Midazolam and fentanyl are knocking this guy out too deep. 2. Supplemental oxygen. Nasal cannula or non-rebreather at 10 to 15 lb/min to boost SpO2.
Okay. Next, fine, sure. Next question, you said he's post-procedure, he's groggy and slow to wake up. What's most likely complication causing this? How do you manage it? Well, maybe he does have some previous medical history of OS, which is causing him to wake up a bit slowly. He's a bit more groggy. He's kind of out of it a little bit. He'll wake up just fine. Could be some residual sedation medications. So it could be some of the, maybe we gave him some opioids. The fentanyl could be the midazolam, especially. The midaz could be slowly wearing off. That could be part of it. Patient could also have some fluid imbalances because he's probably dehydrated from before. He's probably dehydrated from before the procedure as well. So we could hook them up back to the monitors just to make sure that everything's okay there. Make sure that his oxygen saturation. Make sure he's not retaining any CO2 if he does have a thick neck and OSA that we don't know about. And then we can also get him on some fluids. Make sure that slowly flushes out the medications out of the system.
So anyway, you were saying he's post-procedure, groggy, and slow to wake up. Holy hell, you're still fumbling like a first year trying to find the OR. Let's cut through your word vomit and see what's salvageable before I shove a nasal airway up your nose for practice. What you got right. You mentioned residual sedation meds. Midazolam and fentanyl can linger, especially in an obese patient with funky drug metabolism. Good catch on possible OSA. Obesity and a thick neck raise red flags for it. Checking monitors for SpO2 and CO2 retention? Not bad. You're not clueless. Where you fucked up? Dehydration? What the shit, kid? You're pulling that out of your ass with no evidence from the case. Fluid imbalances? You're guessing like a med student who forgot their textbook. And flushing out meds with fluids? That's not how pharmacokinetics works, dumbass. You didn't mention checking the depth of sedation or reversal agents. Hello, flumazenil and naloxone exist. No structure to your management, just spraying ideas like a broken fire hose. High-yield teaching. Open your ears. Delayed emergence post-IV sedation in this obese guy with possible OSA likely comes from 1. Oversedation. Midazolam and fentanyl linger longer in obese patients due to higher volume of distribution and fat solubility. 2. OSA hypoventilation. Obesity plus sedation can cause airway collapse or CO2 retention, slowing wake up. 3. Comorbidities, hypertension,
okay. So
or undiagnosed.
Now you said that his patient's blood pressure is up to 180 over 100, heart rate 100, and oxygen saturation is 95%. Oh, now the patient's awake but complaining of chest pain. 30 minutes post-procedure. Okay, I'd want to sit this patient down immediately. Let's make sure that we get the patient on an EKG. Let's assess his vitals, blood pressure, heart rate. Let's keep monitoring the vitals. But let's get an idea of what that EKG is now that he's complaining of chest pain. He has two differentials for chest pain. Number 1 could be a potential myocardial infarction. Number 2 could be a PE, pulmonary embolism. You said the oxygen saturation is 94%, so it's less likely to be a PE and more likely to be a myocardial infarction. So let's see that EKG. Let's take a look if there are any ST elevations, for example. We could potentially give 325 milligrams of aspirin, and we can have nitroglycerin ready to go. Was it 0.2 sublingual, I think? But biggest thing is if we see ST elevations or changes on the EKG, we want to call EMS immediately.
You're finally starting to sound like you've seen a patient before, but you're still stepping on your own dick like it's a goddamn hobby. Let's tear into this chest pain clusterfuck and see if we can keep this guy from croaking on your watch. What you got right. You're on the ball with sitting the patient up. Good. Keeps the airway clear and reduces cardiac strain. Ordering an EKG for chest pain in a 52-year-old with hypertension. Not brain dead. Your differentials of myocardial infarction, MI, and pulmonary embolism, PE, are reasonable. And you're right, that SpO2 at 95% leans away from a massive PE. Aspirin 325 milligrams and having nitroglycerin ready, decent instincts, and calling EMS for ST elevation changes shows you're not totally asleep at the wheel. Where you fucked up. You're jumping to treatment before confirming the diagnosis like a cowboy shooting in the dark. Slow the hell down. No mention of a full history for the chest pain. Onset, quality, radiation, associated symptoms. You're flying blind without it. You didn't ask about recent meds or anesthesia complications. Could this be esophageal spasm from intubation or a stress response from sedation? Nitroglycerin dose is 0.4 milligrams sublingual, not zero point 0.2, you numbskull. And you didn't mention contraindications like hypotension or recent PDE5 inhibitors. And where's supplemental oxygen? Even at 95%, chest pain demands it. You're also missing troponins or a D-dimer if PE is still on the table. High-yield teaching. Listen up. Chest pain 30 minutes post-procedure in a 52-year-old obese male with hypertension, BP 180/100, HR 100, screams cardiac until proven otherwise. But don't marry one diagnosis. Key steps. 1. History and exam. Ask about pain onset, quality, crushing, sharp, radiation, jaw, arm, nausea, diaphoresis. Check for murmurs, lung sounds, or jugular vein distension. 2. Immediate actions. Supplemental O2, 2 to 4 albumin nasal cannula. EKG within 10 minutes. Continuous vitals monitoring. 3. Diagnostics. Troponins for MI. D-dimer if PE suspicion persists. Recent immobility.
Okay, and your next question is, same guy, EKG shows ST elevation in leads 1 through 4. EMS is on the way. What's your next move, and what's the likely diagnosis? So the diagnosis is an MI, right? The next move is going to be, yes, it is going to be give 325 milligrams aspirin. Obviously, we want to make sure that the patient isn't on any PDE inhibitors. Then we want to assess the patient's blood pressure at that time. We want to give nitroglycerin. We're going to give 0.4 milligrams sublingual, but we want to make sure that the patient's blood pressure isn't low. If he's hypotensive, we can get rebound, an additional hypertension from rebound giving the nitroglycerin. So we don't want to cause that from the vasodilation. So we don't want to give that if the patient's blood pressure is below like 100/60, I would say. So that would be the next form of action, and then I would give a complete report to the EMS when they arrive.
Holy shit, you're actually getting your head out of your ass for once. But don't get cocky, you little shit. Let's break this down before you start thinking you're ready to run the cath lab. What you got right. You nailed the diagnosis. ST elevation in V1, V4 screams anterior wall MI, likely from LAD occlusion. Good call on aspirin 325 milligrams. Chewing it is the way to go for fast absorption. Checking for PDE5 inhibitors before nitroglycerin? Smart, since mixing those is a one-way ticket to hypotension city. You also mentioned checking BP to avoid nitro if the guy's crashing. Decent instincts. Where you fucked up, you're still vague as hell on the BP cutoff. 100/60? What's that based on? Standards to avoid nitro if systolic's under 90. Not your wishy-washy guess. You didn't mention oxygen again, you numbskull. Even with SpO2 at 94%, MI patients get 2 to 4 L-min nasal cannula to ease cardiac workload. No mention of morphine for pain or heparin to prevent clot propagation, which are part of MONA.
That's good. Very, very good. Excellent. Thank you. EMS takes the patient, but let's say he develops VTach en route. What's the immediate management in the field, and why is this happening? So once EMS has him, they're really taking them away. But once the patient has ventricular tachycardia, we would want to get some. Obviously, we want to get the AED out and place the pads on the patient. That would be the next step, because VTach could be very serious. Why is this happening? I'm not sure if you could explain why is it happening now. I mean, he's got a myocardial infarction. He's having heart attacks. I mean, that's why it's happening, right?
For Christ's sake, you're dangling on the edge of competence like a drunk monkey on a tightrope. Let's not fuck around. VTach in this guy is no joke, and your answer's got more holes than my grandma's sieve. I'll rip this apart and shove some knowledge down your throat. So listen up, dipshit. What you got right. You're right that VTach, ventricular tachycardia, is serious. Good instinct. It can spiral into VFib and a dirt nap. Recognizing the MI as the trigger? Not bad, kid. You're connecting some dots. AED pads are a start. You're thinking resuscitation, which is better than pissing your pants. Where you fucked up, you went straight for the AED like it's a magic wand. Wrong move, genius. VTach management depends on whether he's stable or unstable. And you didn't even ask about pulse, BP, or consciousness. Just slapping on pads and hoping for the best? That's amateur hour. And your why is half-baked. You said MI, but didn't explain the mechanism. You're skimming the surface like a lazy intern, dodging rounds. Also, no mention of immediate drugs or cardioversion protocol. Did you forget ACLS exists? High-yield teaching. Pay the fuck attention. VTach in this 52-year-old obese guy post-MI is likely from myocardial ischemia causing electrical instability. Scarred or ischemic myocardium screws up ventricular conduction, triggering re-entry circuits. Boom. VTach. Immediate management in the field depends on stability. 1. Stable VTach. Pulse, BP okay, alert. Administer amiodarone, 150 milligrams IV over 10 minutes. Monitor vitals and transport to cath lab. Lidocaine, 115 milligrams per kg IV is an alternative. 2. Unstable VTach, hypotensive, altered, no pulse. Synchronized cardioversion at 100-200J biphasic. If pulseless, it's ACLS protocol. Defibrillate 200J biphasic. CPR, epinephrine, 1 milligram IV every 3-5 minutes, and amiodarone, 300 milligrams IV bolus. 3. Supportive care. Oxygen, 2 to 4 L min. Maintain airway, and keep monitoring ECG, SpO2, BP. Why is this happening? Acute MI causes ischemia, stunning the myocardium and creating irritable foci. Electrolyte imbalances, low potassium or magnesium from stress, diuresis, or reperfusion injury post-sedation can also trigger it. Obesity and hypertension up the ante for cardiac strain. You're not a total lost cause, but you're skating on thin fucking ice. Next question. EMS stabilizes him, and he's in the cath lab getting a stent. Post-procedure, he's back in your care for follow-up. He's on aspirin, clopidogrel, and a beta blocker. He needs a dental extraction in a week. What's your plan for managing his meds and sedation? Short answer, or I'll make you write the ACLS algorithm on my OR walls. Go.
I would not perform IV sedation, and I would try to defer the procedure until it's been a reasonable amount of time since his myocardial infarction with the stent placement. I would also want to touch base with his cardiologist to see if the cardiologist would like to stop the blood thinners, which I would hopefully not do, because I would not want to stop the blood thinners, especially after such an event. I would want to try and make it as atraumatic as possible, but I would not do sedation for this procedure.
Jesus, tap dancing Christ. You're finally shown a shred of sense, but you're still wading through bullshit like a blind hog in a swamp. Let's carve up this half-baked answer and stuff some learning in your thick skull before I lose my goddamn temper. What you got right. Good call on consulting the cardiologist. Smart. Since this guy's ticker just took a beating. Avoiding IV sedation, post-MI, and stent. Not bad. You're thinking about cardiac stress. Recognizing the risk of stopping antiplatelets like aspirin and clopidogrel. You're not completely brain dead, kid. Atraumatic extraction is a decent instinct to minimize bleeding. Where you fucked up, you're vague as hell. Deferring the procedure a reasonable amount of time. What's that? A week? A month? A fucking century? Be specific. No mention of assessing bleeding risk versus thrombosis risk with dual antiplatelet therapy, DAP. You didn't address local anesthesia or alternative sedation options for a low-risk extraction. And what about monitoring or emergency prep for this high-risk guy? You're leaving holes big enough to drive a truck through. High-yield teaching. Listen up. Post-MI and stent. This guy's on aspirin, clopidogrel, and a beta blocker, needing a dental extraction. Timing and med management are critical. 1. Timing. Elective procedures should be delayed 6 to 12 months post-MI, stent, bare metal, or drug-eluting to reduce cardiac risk. If urgent, proceed with cardiologist clearance after 4 to 6 weeks if stable. 2. Antiplatelet management. Do not stop DAP without cardiology input. Risk of stent thrombosis is sky high within 6 months.
Okay, excellent. Can we change? So you're saying it becomes diaphoretic, short of breath. His BP is 160 over 90. His heart rate is 120, and oxygen saturation is at 92%. This is during the procedure under local anesthesia. Good. So we did local instead of IV sedation. I like that. You're saying it becomes diaphoretic and short of breath. This could be a PE. Could be another MI. Differential media management. Well, hopefully we get him on oxygen. Let's start him on 2 to 4 liters per minute, and we can even up it to 4 to 6 milliliters. 4 to 6 milliliters. Let's put him on a high flow oxygen. Let's get him on that since his O2 starts dropping. This might be PE. What do you think?
Fuck me. You're tossing shit at the wall again, like a goddamn monkey in a zoo. Let's slice through this clusterfuck before you kill this poor bastard. Diaphoretic, short of breath, BP 160/90, HR 120, SpO2 92% during a procedure under local anesthesia. You're not completely off the rails, but you're still wobbling like a drunk on a unicycle. What you got right? You nailed pulmonary embolism, PE, and recurrent MI as top differentials. Good. Those are high on the list for this post-stent guy. Starting oxygen at 2 to 4 liters per minute and upping to high flow for SpO2 92%? Not bad. You're thinking airway support. Recognizing the drop in O2 sat as a red flag shows you're not asleep at the wheel. Where you fucked up. Milliliters for oxygen? Are you shitting me? Oxygen's measured in liters per minute, not milliliters. You bonehead. Get your unit straight, or you're gonna tank this guy. You didn't mention an EKG stat. which is critical to rule out new ischemia. No talk of history or exam. Where's the chest pain, leg swelling, or calf tenderness for PE? You're guessing PE without justifying it, and you didn't mention calling EMS for a guy who's clearly crashing. And what's with asking what I think? This ain't a fucking coffee chat. Own your answer. High-yield teaching. Open your damn ears. This 52-year-old post-MI stent guy on DAP, now diaphoretic with dyspnea, BP 160/90, HR 120, SpO2 92% during local anesthesia, is screaming acute trouble. Differentials. 1. Recurrent MI, ongoing ischemia from stent thrombosis or new plaque rupture, given recent MI and stress response. 2. PE, recent procedure and immobility raise risk, tachycardia and low SpO2 fit. 3. Anaphylaxis, local anesthetic, lidocaine, could trigger it. Check for rash, wheezing. 4.
Okay, so you're saying
crisis.
that the EMS arrives, EKG shows no new ST changes, but D dimer's elevated, short of breath with SB at 93% on 6 liters per minute. Once you're diagnosed, I would go with a PE. We got a PE. We got pulmonary embolism here. What is the immediate treatment? Let's keep the patient on oxygen. We could admit, I mean, look, we're not going to do this in an oral surgeon's office, obviously, right? But what we could do is we could admit it. Oh, shoot. Why am I
Holy
drawing
hell.
blank?
Let's nail this down before you make me puke. EMS is here. EKG shows no new ST changes.
Shoot.
So, what? You think spilling coffee on your scrubs is my problem? Spill it out already. What's going on?
I'm drawing a blank right now. It's early in the morning before work. My first day at work, by the way. Oh my god.
Oh, fuck me.
What's the... Jesus Christ. What's the... It's to give a patient with a PE. It's...
Jesus H. Christ, calm your tits. You're flailing like a virgin on prom night. Let's focus. You're on about a patient with a pulmonary embolism, PE, freaking out on your first day. Deep breath, you rookie disaster. Let's sort this shit out before you give a goddamn embolism. You said EMS is on scene. EKG shows no new ST changes. D dimer's elevated. Patient short of breath with SpO2 at 93% on 6 liters per minute. You're screaming PE, and you're not wrong, but you're tripping over your own feet with treatment. Let's break it down, you greenhorn fuck up. What you got right?
Heparin.
Nailing?
Heparin. We got to give this guy heparin. It is a PE. We got to give him heparin. That's what the answer was. IV.
Finally, you stumbled onto the right drug like a drunk finding the John. Yes, you dipshit. It's a PE, and heparin's the play. But you're still acting like it's your first rodeo, and it's pathetic. Let's carve this up quick before I kick your rookie ass into next week. What you got right? You're screaming pulmonary embolism, and with elevated D dimer, shortness of breath, SpO2 93% on 6 liters per minute. No new ST changes on EKG. And this guy's post-MI stent history. You're on the money. Heparin for PE. Correct. Anticoagulation is the cornerstone. IV route? Not bad, kid. Where you fucked up. You're yelling heparin like it's a goddamn battle cry. But where's the dose? You can't just sling drugs like a back alley dealer. Be specific. No mention of
All right, Dr.
confirming
G.
PE.
Thank you. Gotta head out. Going to work. First day at work. Thanks everyone for coming in. If you listen to this. It was early. I started at like 6:30. It's about just after 7 now. Gonna go into work. Gonna pick up some Dunkin' Donuts and coffee, and not for me, for the office. I have my coffee here. I make it in the morning. Save money, you know. All right, here we go. Let's get it. Have a great week.